So my name is Juergen Konczak. I am a professor for biomechanics and movement neuroscience, as I said in my talk, at the University of Minnesota. And I am really a motor control specialist, and I got into research on spasmodic dysphonia a good 8-9 years ago now, since I was working on Parkinson's disease and other forms of dystonia before. Yeah, so that's how we got into this. And here we've been on a road for, as I said, roughly 8 years and trying to move forward, hopefully getting to some meaningful interventions that SD may one day actually be using.
So you want to, Juergen, you want to talk a little bit about the work that you and your team are doing and some of the key points, and then if Arash wants to jump in and introduce himself and cover some aspects of that too, I'll leave it to the two of you how you want to do that.
Yeah, so as you, for those who have actually watched the short presentation, you've seen what are we trying to do. We came from the notion that if you're trying to understand movement disorders, neurological movement disorders, a lot of them are associated with some form of somatosensory deficit, proprioception or touch, as those two modalities are important for motor control. And then really, as I started working with people with SD, we began to literally measure proprioceptive thresholds actually of the arm at that time and found, wow, these people may have thresholds. And this got us all started then to think about how can we possibly modulate activity in cortex, and that modulation hopefully will result in normalizing brain activity that we see in dystonia and focal dystonia and in spasmodic dysphonia in specifics. And what our approach is a non-invasive approach. We basically try to stimulate mechanoreceptors around the larynx. And we have shown that if you do that, it will really trigger a very quick response in somatosensory motor cortex, and it normalizes motor cortical activity. And what that then means is it will help people with spasmodic dysphonia to speak with less effort and more fluent. And so that's our first study. And what we are doing right now is we are trying to get into a study also funded through NIH, where we are looking for long-term effects of that intervention, meaning people will undergo about 11-week intervention at home to do this. And that's where we are in the middle of it. And I can speak more about it in detail if people have questions. And I think the other technology part I will leave probably for Arash to explain.
Okay, so thank you, Dr. Konczak. Hello, everyone. I'm Arash Mahnan. I'm a PhD candidate in Dr. Konczak's lab. So far, basically my role, I'm the lead engineer in a project that we are moving the technology forward to a wearable device. Can you hear me well? Or I think I can. Okay, good. So what I'm doing what we are doing basically now is that we are building a device, which is a wearable device that goes around the neck. There is a microphone and accelerometer inside the device. And as Dr. Konczak mentioned, so we are working on this non-invasive approach that we apply the vibration to the neck. So what the device is doing is that it will capture the voice, and since SC is related to the speech, so when the person starts to talk, we apply the vibration to the neck. So that's the technology we are working on it, and we just received a grant from NSDA to further develop this approach. I can go in details if you have more questions.
All right, great overview, Arash and you and Juergen. So, Dr. Yiu, would you introduce yourself, please, and talk a little bit about the project with Dr. Pittman that you are working on?
Sure. Hi, everyone. Thank you so much to Charlie and to Kim and the NSDA for the invitation to be here. My name is Yin Yiu. I'm also joined by Dr. Carolyn Baylor, who you can see in the bottom is not my twin, but she couldn't log on with her link, so I sent her mine, but that's why her name is the same as mine. So my name is Yin Yiu. I'm a laryngologist at the Texas Voice Center at Houston Methodist Hospital. If some of you know Dr. Dick Stasny or Dr. Puthekti, I've joined their former practice, and then that's now been incorporated into an otolaryngology department at the hospital. So as a newly minted laryngologist, I feel incredibly honored to have been invited to join this esteemed panel of researchers who are far more expert in these topics than I can claim. I really feel like I'm boxing out of my weight class here, so I'm grateful for Dr. Baylor being here to support me a little. I was very fortunate to be entrusted with this project last year by one of my fellowship mentors, Dr. Pittman, who couldn't be here today. He had really envisioned this collaboration with Dr. Baylor, and she's basically, I'll let her introduce herself as well, but she's been working on creating and validating this outcome measure called the Communicative Participation Item Bank, or the CPIB, for many years at the University of Washington. And it's a relatively new outcome measure that was formulated within the relatively new NIH PROMIS guidelines, and it intends to capture the impact of different communication disorders, including spasmodic dysphonia, on communicative participation, which is basically taking part in life situations in which knowledge, information, ideas, or feelings are exchanged. And the driving force behind this project was really the realization that there's not a great standardized outcome measure for SD. Obviously, there are many, and different research projects utilize many different kinds, including the VHI-10, including Likert scales, but there's just not one that's kind of well captured by everyone out there. And clearly, research into finding better treatments for this disease is extraordinarily important and being conducted by many of the innovators here, as well as on some of the other panels earlier today. And so we hoped by validating this new CPIB for SD, it can kind of serve a role into being a widely used outcome measure to really capture the construct of how spasmodic dysphonia affects communicative participation. And then with ultimate goals of really optimizing clinical treatment for people who have the disease, as well as supporting our research endeavors. So I'm happy to take questions on the specifics of this project if you're able to listen to the presentation. It's relatively short, but I'm very, again, grateful to have Dr. Baylor here again, as well as a resource for you if you have specific questions about the questionnaire. Thank you.
Thank you, Dr. Yiu. Carolyn, would you introduce yourself and any additional comments about the project that you guys are working on?
Yes, thank you so much. And again, I apologize for the late entry and the wrong name. I've been teaching classes via Zoom for 5 weeks, and it's mostly gone great until Saturday morning. But thanks to my husband in the background for getting me on here. So, so yeah, thank you for the invitation to join. Just briefly, I am at the University of Washington in Seattle. I'm a speech pathologist, and my research is really focused on the lived experience of communication disorders, spasmodic dysphonia among them, but also other communication disorders. And I really do work in both qualitative research to better understand the lived experience and the impact on life participation, and then using that information to look at how can we better capture that in clinical outcomes, such as in the patient-reported outcomes and the CPIB questionnaire that Yin mentioned, and also, looking at how can we improve our holistic patient care, for the experience of living with spasmodic dysphonia. So that's a little background on kind of the bigger landscape of my work.
Great, thank you, Caroline, appreciate it. Okay, Dr. Michael Hemmer, would you introduce yourself and tell us a little bit about your work and kind of hit the key topic points of your presentation?
Sure. Thank you, Charlie, and thank you, Kim, and thank you for each member of the panel. It's a joy to be together. And for those of you that we can't see but that are with us, thanks for joining us on a Saturday morning. or Saturday noon or afternoon, depending on what time zone you're joining us from. And I just want to highlight, as Charlie mentioned, each one of our presentations is available to watch at any time, so you can get the full story. So my name is Michael Hammer, and I direct the Wisconsin Airway Sensory Physiology Laboratory. And so I'm by training a neuroscientist and also a speech language pathologist. And so similar to what my colleagues have talked about, I'm very interested in kind of the intersection between the neuroscience, the sensory motor control of the larynx in particular, and also how that relates to the clinical experiences of those with spasmodic dysphonia, as well as we study people with Parkinson's disease as well. And specifically what we're working on and what I've highlighted in our presentation that you can view either before or again after this is specifically the question that Juergen's raised, which is, this issue of the interaction between motor and sensory features that interact between the larynx and the brain. And so we've had a sense that there's an issue with somatosensory integration and laryngeal control and spasmodic dysphonia. And so that's been a big focus of our lab, is to really define how the brain interacts with the sensory receptors or the touch receptors within the larynx that guide vocalization, and how that contributes to that interruption of the forward flow of voice and speech in individuals with spasmodic dysphonia. So we're looking at directly how those touch receptors in the larynx are affected, and how treatments specifically can change those mechanisms that governs and integrates the sensory input. So we're really interested in unpacking how those mechanisms work in greater detail, how those shift with treatment, so that as a panel, in a sense, we can all contribute to improvement of assessment and treatment for those with spasmodic dysphonia. And one of the great frustrations I found as a clinician is the prolonged time it takes for someone to get an accurate diagnosis of spasmodic dysphonia. And some of you may have had those experiences in your own journey. And so part of the goal is to try to shorten that timeline, improve diagnostic accuracy, and then hopefully move towards a more appropriate treatment sooner rather than later, and try to improve the treatments we have. So it's a pleasure to be here. Thank you.
Thank you, Michael. Appreciate it very, very much. And again, let me encourage all of you out there. I know you have questions, so please get those into us. The easiest way is with the chat box. And let's learn more about these projects. And I know that you guys are not bashful about asking questions, so please let's get those questions flowing. And Kim and I will kind of moderate the discussion going forward here and with the questions. I would just start off, Juergen, maybe with you and Arash, if you could comment a little bit about how the pandemic has affected your research and your study, and kind of where you are at this point, and what do you expect over the next several weeks going forward in terms of volunteers being able to restart, if you will, or how they can get involved as well, even as initial volunteers.
Yeah, I can speak to this. Of course, our longitudinal clinical trial, yes, there's been a devastating effect of COVID-19, because we had over 20 people enrolled. You know that we had people from all over the United States flying in, getting tested, go home with the equipment, come back at week 6, then come back at week 11. And of course, now with the travel restriction and the in-person testing restrictions, all of this has crumbled. So we are in official state of hibernation. That's how the university calls it. So our lab is hibernated, or hibernating, and we probably can begin coming back to the lab, but when in-person testing will be allowed. At this point, it is not. I think we're probably looking at something June or later. And we'll, for some of them, we'll just have to start all over again. Yes, so it's been not a very good experience. But, you know, it is what it is, and we'll try to do the best of it.
Dr. Hammer, you probably have had a similar experience too.
Yeah, that's true. I think the, you know, safety first, and the types of measures that we're all involved in involve voice, which means there's airflow, and so that aerosolized nature of the things we do and are most interested in really limits what we can do. Safety has to come first though, right? We can't make the situation more difficult for people when we're striving to try to make their lives better. I'd be curious, Dr. Yu, how this is impacting the access to healthcare for those that seek your services.
Yeah, we've had so many Zoom visits because I guess I'm the only clinician here, but as a otolaryngologist, obviously working in the nose and the throat and all that has been very challenging. I think I only have a small amount so far of spasmodic dysphonia patients. My partner has more, and obviously across the country there are many more. I feel that we have been trying to roll with the punches a little bit, and I know that we people are starting to gradually do them again with, you know, safety protocols, wearing masks. Fortunately, a lot of the injection types that we're able to offer are not aerosolizing if the patient is able to not cough, but obviously you can't always prevent that. So it's been a very ongoing challenge, certainly. I think a lot of us have shifted to telemedicine for those of you who are not really in the healthcare in terms of seeing patients. So a lot of us have been able to at least triage from that perspective, and that's been wonderful. And then kind of deciding when people are able to come in. We're all still around, none of us are taking a vacation, but I think we're all very carefully triaging it, again with safety. You know, safety does come first, and so it has been a challenge, but it also is changing rapidly, and I think our community of clinicians has done a good job to try to stay on top of it and be as available to our patients as possible, but it certainly has been a challenge as well.
Yeah, I see in the chat there were like 2 questions for me. Kim and Charlie, tell me how you want to do this. Should I just respond, or you wait, or?
Yeah, why don't you go ahead and respond? I know there were a couple of questions I was just looking at, so why don't you and Arash respond to those?
Yeah, so the first one was like, are we adding new volunteers? Yes, we do. So literally we are enrolling, and you can potentially contact us and go to our website and contact Divya Bhaskaran, who's a study coordinator. So yes, we are enrolling. Right now, we don't have an official start date yet, as Michael said. Right now, safety comes first, and as soon as we have that, we will get going, and we'll just have to probably push much harder in a shorter time to see as many people as you possibly can. And there was another question. Can you please tell us more about the sensory motor intervention that you are exploring? Shall I speak a little bit more about this?
Sure, please.
So, you know, this goes back to what Michael had said too. So what we are trying to do is we apply vibration here. So these are little tiny vibrators, similar to what you have in your cell phone. And when you turn these on, you feel like a tingling sensation. And if you do this at the right frequency, it will stimulate these mechanoreceptors that Michael had outlined in his talk in great detail. And what we have shown is that if you do that, you will modulate activity in the brain, namely somatosensory and motor cortex. And what that will do, it changes the activity of motor cortical neurons. And what we then see is that speech symptoms in people with SD go down. And we just published a study this past year where people had roughly 30 minutes of vibrotactile stimulation, and about 2/3 of the patients that we saw in our sample benefited from it. Website address, yes, hsc.umn.edu. That's our website, hsc.umn.edu.
There are also some questions for you in the question and answer box if you want to take a look at that.
Yeah, so actually one of them is about, is the research is limited to Adductor, the NIH one, the R1 yes, it's limited to Adductor, but the grant that we received from NSDA is on Adductor. So we have both of them. So if you have either of one and you want to participate in our research, you can just communicate and you will be enrolled in either of those two studies.
And I can very briefly add to this. So for the NIH trial, we've restricted this to AD, but we have seen AB before. And I can tell you also it worked with the few people with AB that we have seen. So there doesn't seem to be that distinction. But again, we don't have enough data to really make a conclusive to reach to a conclusive to a conclusion in that respect yet.
I noticed a question, Juergen, there in the Q&A relating to some work that Dr. Christy Ludlow did a few years ago relative to swallowing. Could you address that?
Yes, Christy Ludlow and her group also had this idea that vibrotactile stimulation may help. Now, what she did, this was people with swallowing disorders. And the type of vibrator that she used were much bigger vibrators with a larger amplitude. And if you take those and you put them on here and you turn them on, you may elicit a gag reflex. So which, so to speak, you automatically turn on this reflex loop that is part of swallowing. Now, what we do is a lot less. So we've worked, we did a lot of trial error. What could be a good vibrator that provides the effect, but is also very tolerable to be used. So you don't want to have a huge thing here at your voice box that induces a large amplitude vibration, not very meaningful for people with SD. So that's why we came up with these very tiny vibrators. And if you tune the frequency properly, you'll start seeing effects. And that's basically what we've done.
Good, good. Dr. Yiu and Carolyn, could you comment a little bit more about the relationship of using the CPIB with VH10, perhaps what some of the complementary approaches to using those are for researchers? And then a follow-on to that would be talk just a little bit about the project where Dr. Pittman is looking to utilize this approach, the CPIB.
Do you want me to start? You're still muted. I can start. So with our project, we did, it's a good question. So we did basically in our survey coming up with this project, I think we had looked at a couple of different studies that had identified certain outcome measures, and the VHI-10 and the VHI in general were the ones that were kind of most widely adopted, I would say, from a patient-reported outcomes standpoint. And so we did utilize that kind of in our study as a way of also determining if they had similar constructs. And so we did the similar data analysis with the VHI-10 as with the CPIB questions. And so we did find, again, if you review the video, we did find that both of them were able to demonstrate a change in change with treatment, and then they were also moderately strongly correlated. And so our conclusion from that was that they do have kind of similar but not identical constructs. Obviously, the VHI-10 is very widely adopted and has a really good way of measuring physical, emotional, and functional impact. And so I think in Dr. Baylor's initial study, she had mentioned it kind of depends from a clinical standpoint what you're looking to assess. The CPIB is really looking at a very unidimensional construct of communication participation and able to isolate that. And when they made their item bank, they took a lot of care into making sure that it was as unidimensional as possible. And so I think we've had this conversation many times amongst ourselves as we've kind of, certainly are not by any means downplaying the VHI-10 as it's very monumental and very important. We're trying to come up with a way of seeing how we can incorporate kind of both. And so I don't know if Dr. Baylor has other thoughts about that.
No, I appreciate your comments about that. And I really want to reinforce it's not like, trying to pit one questionnaire against the other, so to speak. The VHI and the voice-related quality of life and other questionnaires have really been the trailblazers in terms of bringing patient-reported outcomes into our patient care. The CPIB does offer a little bit different perspective, kind of focusing on day-to-day communication situations, so it has a slightly different construct. One of the motivations behind it, which may not be quite as directly relevant to this group, but as a speech pathologist, many of the questionnaires, patient-reported outcomes in our field, focus specifically on a single condition like voice or hearing, or aphasia, a language impairment, different types of things. And I think when we start talking with many of our patients, we realize that many of them are dealing with multiple communication challenges, a voice injury plus hearing loss, a speech disorder plus maybe some cognitive decline with aging. And the CPIB offers the opportunity to kind of get a more holistic view as opposed to focusing on a single symptom, which can be helpful in other clinical situations.
Great, good explanation. I know there's been some questions that we have received too. What are the differences, and are there some conditions or situations where one may be more adequate, if you will, or more relative to particular conditions or aspects? And then I guess one thought I would quickly have, Carolyn, is in terms of research, is one perhaps a little more usable or whatever?
Well, one of the things about the CPIB is, and these instruments really kind of belong to two different generations, so to speak, of instrument development. And the CPIB was really developed with newer methods coming out of some NIH programs targeting kind of increasing the emphasis on patient-reported outcomes. Things like more rigorous stakeholder engagement in developing the questionnaires to be sure they represent the viewpoints of the patients, and newer statistical modeling techniques that theoretically provide more precise measurements. One of the things that can be helpful if we get this far is that newer instruments developed with these newer methods can use computerized adaptive testing, where the instruments, essentially the patient can sit at a computer, and based on what questions they answer, the computer chooses the next most appropriate question for them. And with that type of administration, you can get measurement that is as valid and reliable and precise, or even more so, with fewer items. So where even short forms with 10 items or 15 items, sometimes with this computerized adaptive testing, you can use 4 or 5 items and get the same precision of measurement. I think our big challenge now is how do we get that computerized adaptive testing really implemented in healthcare settings so it's easier to use, because it would just be so much more faster, efficient, lower burden of administration if a patient can answer 4 or 5 questions and get the same measurement quality. So that's really kind of the long-term goal that we want to get implemented.
Okay. Would that also include, Carolyn, creating an app for smartphones where you might actually take some voice samples in addition to getting the so-called written response or the verbal response?
That would be a great idea, to be able to capture kind of this momentary analysis at any point in time. How does your voice sound? How are you feeling about your communication at that moment? And that would be wonderful to have. So yeah, there's a lot on the horizon that can be done there.
Thanks, Carol. Kim, I know we've had some other questions coming across the chat box. You have some there.
Yeah, I think Dr. Hammer, do you want to respond to the one question regarding sensor motory pathways? Oop, you're muted. Hang on. Okay, let's try it again.
Yeah, can you hear me now?
Yes.
Sure. So let me go back to that. So I'm looking at that question. We've got a couple areas where questions are coming in. So thank you, everybody, for sending these great questions here. One of the questions was, what does the spasmodic interruptions to voice that happen in spasmodic dysphonia? And it's a little bit easier to explain this maybe for spasmodic dysphonia, AB spasmodic dysphonia. Maybe there's a similar mechanism, but it's less common. And so we might have a few more questions about that. So we'll focus on adductor spasmodic dysphonia. And so similar to what Dr. Juergens mentioned earlier, and I think our clinical experiences across the board of our members here have observed, is these interruptions of voicing tend to often happen unexpectedly. And so from our perspective, from our lab and our work, it seems that typically when we speak, for those that do not have spasmodic dysphonia, the voice comes out fairly effortlessly. Not perfectly, but relatively smooth without a lot of excessive effort. And so one way of thinking about the pathophysiology maybe of spasmodic dysphonia is these touch receptors that line the larynx, and I talk about in detail in my presentation for a couple of things. One, if food or drink goes down the wrong way, cheese curds in Wisconsin, or whatever item you like to eat the most, if it goes down the wrong way, then hopefully you will cough to protect the airway. And that's very important. The larynx is, the purpose of the larynx is to keep the airway open for breathing and to close and protect the airway if something should invade. And so clinically, we're really interested in helping people with all those kinds of issues. The unique feature in spasmodic dysphonia is that a person goes to speak and the voice has these interruptions. The airflow, the closure of the vocal folds is so tight that airflow stops and sound stops. And so one viewpoint is that perhaps the normal movements of the larynx itself themselves are moving. Those movements of air and the structures themselves, the vibration of the vocal folds perhaps creates sensory input itself to those touch receptors just by the normal movements of voicing. And that for some reason, the brain or the brainstem, whatever the neural mechanism might be, which is our focus, takes that information that's should be no surprise. And there's this surprise defensive posture that the larynx takes when all you're trying to do is talk. And then those interruptions occur specifically during speech and voice. And so in terms of the sensory motor pathways, it may be that instead of the brain saying, it's okay, Michael's just talking, relax, you don't have to defend the airway, we're expecting speech and voice to come out. Instead, the larynx is extra vigilant or sensitive or whatever the right word might be, and takes a defensive posture against its own movements. And so that interruption might be the reaction to the self-generated sensory input just because of the actions, the normal actions of the larynx. Is that indeed true? And some of our data certainly agree with that perspective. And that's why it makes a lot of sense as we work together to understand the patient's experience. So that's where we in our lab really get a sense of what the individual's experience is like, as well as these physiologic measures. And I think that's again where Dr. Juergens' work is so elegant in terms of directly looking at what we think are these somatosensory mechanisms while we're trying to really, I guess, dig deep and make sure that we have a good fundamental understanding of those mechanisms. So I don't know if that's helpful. So if the person who asked that question, feel free to type in a follow-up and if there's something else we can do to be helpful. So that's one way to view what's happening.
Dr. Konczak, do you want to jump in and answer the question that was asked also?
So there were two questions. I think there was one that was related to whether we are, what kind of patient populations we are restricting our clinical trials. And are there, if you have other presentations, meaning, for instance, you have tremor plus, or if you have other forms of dystonia, cervical dystonia plus SD, would we consider those? So let me answer this, and I already typed to a particular person just before. So right now for our clinical trials, from a science point of view, you would like to make it as clean as possible, right? So that means you would like to have only AD, only AB, and nothing else. The reality of life is that there are possibly other presentations at the same time. So what we are trying to do right now, and this question we have been getting repeatedly, I would encourage all of you, just contact us. We'll try to see what we can do. Ideally, if we get a large number, we can start doing subgrouping, meaning we could potentially have a group where we have, okay, AD, SD only, and then you get AD plus tremor. Is this different? And we know already that in cervical dystonia, they may be differently responding. Do we have enough data on this? Absolutely not. So in short, feel free to contact our study coordinator, Dr. Bhaskaran, get on the list, and if we can make this work and we have the means, we will try to get in as many people as we can possibly can. The second question was about when would a vibro-tactile stimulation device be commercially available? Yes, that's a dream. That is where we will try to go. We have patented the technology, and now with the help of NSDA, we are trying to go to a second generation prototype. And that will still require testing. And then we will likely have to go through FDA approval, another process, which costs a lot of money. So short answer to your question, it will probably take at least a year before we have a fully workable second generation prototype that is close to what one can commercialize. And we may be able to then already produce them at a small scale. You need a medical manufacturer of this. So you can't just, we go beyond just doing this in the lab, just building stuff in the lab. Then, you know, you have to have quality control. So there's a lot of things that we have to do in order to get there. And likelihood at that point, we either license our technology to a medical device maker who has all that knowledge available, or we will try to form a startup company that works with a medical device. That's where we are right now. So yes, we'll still have to be a bit patient. And Arash, if you want to add a little bit to it, anything I forgot?
I think it was complete. So yeah, it's in the process. Any medical device, if you want to bring it to the market, takes a long time. It's a process of going different, I would say, stages that, yes, maybe we can build something in the lab, but when we want to go to the market, that has a lot of requirements that we need to pass and have them. So it's a working process, and we are working on it. We are doing our best to move it forward.
Another question we had was, it ties into the idea of new therapies. And I'm wondering if the new work that you guys are doing, Carolyn and Dr. Yu, how does your work tie into showing the efficacy of new therapy treatments?
Yin, I might let
Good
you
question.
lead on that with the work you're
Sure.
doing with Dr. Pittman.
Yeah, so I think actually the what in this project, like I said, was already kind of getting off the ground prior to me joining, but I know that at the initiation of this project, one of the reasons of doing it to begin with was, I don't know if some of you know that Dr. Pittman has published on using a neuromodulating implant potentially for treatment of spasmodic dysphonia, and he ran into quite a few issues from insurance standpoint in terms of getting things covered, because it was very challenging for him to present outcome change, and also from just industry partners in terms of having them fund him for the same reason. So the background and backstory of this whole project was to answer that question that you have, basically, is we need a better method of that's very well kind of regarded and kind of widely adopted by everyone, both in the clinical community and the research community, to be able to do exactly what you asked. So that is the goal. Of course, we're in the kind of early stages of that, but those are our kind of long-term outcomes. And I know that that is certainly the research question or clinical question that he was trying to answer when going into this. But I think there's still quite a bit of work to be done before it will be at the point that we want that. But certainly that is, it's a great question. Does that answer your question?
Absolutely. And I think what it shows is how all of these research projects complement one another. And that's so important. I know there was a question about whether or not there are separate labs for Dr. Hammer and Dr. Konczak. And again, it's complementary research. And as an organization, that's one of the things that we do look at when we fund research grants.
And I may add
Go ahead.
the work that Yin and Carolyn are doing. And, this is, here we are trying to figure out whether a particular intervention may work. And this is exactly the issue that Dr. Pittman has. So now you have something and you try to figure out, will it work? The first thing you have to figure out or have to determine, what is the state of these people with SD that you're trying to enroll to begin with? And if there's no consensus of what is considered a mild, a moderate, or a severe case of SD, you already have a problem. You have a problem research-wise. And this is what we all face. So thank you both for really pushing this issue, because it will be important. I have seen this, for instance, in Parkinson's disease. There's a unified Parkinson's disease rating scale, widely accepted. Everyone is clear. So if you use that in a study on Parkinson's disease, that's what you describe. We do not have something similar yet for SD, but I'm optimistic that we soon have something with your work.
Thank you. And I'll have Carolyn jump in too, but I think one of what she mentioned briefly, and that you should look back at all of her, she's published many publications already on this survey, but if you have more interest in it, I think one of the points of how this was developed with kind of modern methods of IRT and all of this is that it is more sensitive to, in the way that it's scored on a T-score instead of on just kind of a raw score. And so the point is that it should be able to delineate a little bit better a mild versus moderate versus severe. And as well, I think it in its natural form is a 46-item question bank, and then from that is derived either the computerized adaptive testing or a 10-item short form. But theoretically, you can actually create other short forms from those 46 questions, potentially for different diseases, and then recalibrate it from a scoring standpoint. So then the scoring can be compared across different forms, and also it's much more complex than just spitting out a raw number. So I think that's one of the things that she's hoping to accomplish from her work. So
yeah, Carolyn, could you just comment briefly to what Dr. Yu was talking about as well, and Juergen mentioned, what are the other conditions, voice conditions, that the CPIB has been verified, if you will, for?
Right. So we have data behind it for vocal fold paralysis, head and neck cancer, spasmodic dysphonia, Parkinson's disease, multiple sclerosis, aphasia, which is a language impairment due to stroke, a little bit with ALS. And, you know, what we have found so far is that those groups kind of perform from a statistical perspective so similarly with this instrument that we are feeling more and more common that you could probably use it across a much wider range of voice and motor speech conditions. So if you're working in a voice clinic with people with muscle tension dysphonia and benign lesions and that sort of thing, you know, I'm not sure that we necessarily have to go through the statistical methods for every sub-voice population. With that, I'll say we have found 2 exceptions, and we do have 2 new modified forms under development. For people who live with hearing loss as their only communication disability, we need a slightly different combination of items in the short form to kind of be tailored for hearing. And this is a different population entirely, but I'm working on another project with people who are transgender and who are working on voice and speech changes related to gender transition. And because of some of the wording in the CPIB, we need to modify some of the wording. So I would not use it with people who are transgender if you are seeing those in your voice clinic. We're working on a new version that I'd be happy to share with people.
Just a quick follow-up, Carolyn and Dr. Yu, I'm curious, have you guys been contacted by any research teams that may be looking specifically to do work on SD or vocal tremor or vocal fold paresis, for example, just to see what you guys are doing and if the CPIB could be used for their project?
Well, I've been doing work with the voice clinic at the University of Washington Medical Center with Tanya Meyer and Al Muradi and Dr. Hillel before he retired, Al Hillel. So, you know, I work with that group on some research options. Yin, I don't know if you have other connections.
So I know that we presented this actually a week ago at the American Bronchoesophagological Association as well. And so I know that Dr. Pittman has received quite a bit of input from different clinicians. So again, we're kind of hoping to take these 2 presentations in a row and kind of run with it a little bit. And we certainly would like to hear from anyone who's interested in participating. So.
Great.
And
well, I think it's been a terrific session as I look at the time here. It's amazing how rapidly it gets away. And so just, I think if we could wrap up in a couple of more minutes, any quick closing comments either one of you would like to add?
There was just one more chat here. I just see briefly, I can just quickly talk about approximately 2/3 of your patient had a response. Was a response only while the vibration was activated or sustained? So that's, of course, is a big question. How long does the effect last? I can tell you when we did this 30 minutes, it will last for at least another 20 minutes. So we found that. So that's short term. Now on our long-term clinical trial, because that's a real open, important question, right? So now what happens if you get vibration over days or weeks? Will it build up? How long will it last? Will it just fade away after an hour every time? We don't really have a full understanding of this, but that's exactly one of the big questions that we're trying to see in this long-term 11-week clinical trial.
Great. Thank you, Juergen. I want to thank our panelists today. Fantastic discussion. Just incredible work all of you are doing. Again, thank you for your dedication and your commitment. I want to remind our audience that if they have additional questions or they feel that we didn't provide enough information on a question perhaps they asked, if you guys will send those to us, we will ask our panelists to respond to those and we will get the information back to you. So again, my appreciation to each one of you for joining us today. And So I think at this point, we will wrap up this session and hopefully everybody will join us for the next session starting here in a couple of minutes. Thank you, guys. Appreciate it.